Hello and welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Podcasts share their desert island drugs and joyful patient stories.
Welcome to episode 6 of the Oral Apothecary. Coming up in today's episode, we're joined by Dr Mark Taubert. Mark is an NHS consultant in palliative medicine and an honorary professor at Cardiff University School of Medicine. Our micro-discussion will look at treatment burden, patient behaviours and the use of medicines at home. As usual, Mark, as our guest, will get to share a desert island drug, a career anthem and recommend a book for the Oral Apothecary Library. Before I welcome my two fellow apothecaries, STC and Gimmo, just a quick thanks to you, our listeners, for all your 5-star reviews and the messages of support on social media. Here's a review for you, look. It reads, 2 instalments have been released so far from the series. The format is familiar from 1,000 other podcasts. Friends shooting the breeze about their lives and the issues of the day. The production is classy, however this is part of the problem, as you know that it will be a little too slick. What a great review. Unfortunately, it's not one of ours, but it so could be. In fact, that's a review from the new Springsteen and Obama podcast, Renegades, available on Spotify, which I can highly recommend.
I've heard they've modelled their podcast on this one, so
they'd be right to. STC is in Bournemouth and Gimmo's in Cardiff. Welcome both.
Hello, hi Jamie.
Evening both.
Gimmo, what have you been up to?
I've just been enjoying the weather, I think. The sun's come out for the first time in ages, so I've emerged into the sunshine, been out on my bike, and the exciting life I lead, I've been jet washing the patio. That's what I spent my Sunday doing. It's fantastic.
So you're a mammal like me then, Gimmo?
I am, yeah. I think you mentioned swimming last week as well. I like a swim as well, so we'll get on that one day.
STC?
Well, I've been having a lot of grief about who I sound like on the podcast. Any guesses?
We're not allowed to swear, are we?
Bruce Springsteen?
Well, apparently my oral doppelganger is Alan Partridge. No, it's a true story. Patients have actually stopped me mid-consult and said, Ooh, I know who you sound like. What are you on about? No, anyway. But no, nothing much has been happening.
Let's move on. My great pleasure to welcome Dr. Mark Taubert to the Oral Apothecary Podcast. As I mentioned, Mark is an NHS consultant in palliative medicine and clinical director at the Edinburgh Cancer Centre in South Wales. It's not your average medical biography. He's given TED Talks, written for the Washington Post and other international media, and lots more. His posthumous letter to David Bowie, which discussed the importance of good end-of-life care, went viral and has been publicly read by, amongst others, Benedict Cumberbatch and Jarvis Cocker. Hi, Mark, and welcome to the Oral Apothecary.
Hello, Jamie. Thanks for having me today.
Yeah, great. Welcome. I know you've always got a lot going on, Mark. What are you up to at the moment?
Right now, I'm just wondering why you said Bowie and not Bowie.
See, yeah, I did that deliberately.
But I mean, it's sort of one of those controversial topics, isn't it? But yeah, I've always thought it's David Bowie, and I think there's a YouTube clip somewhere, and I'm going to find it for you, where he says, "My name is Bowie, not Bowie." But
I stand corrected. But we did discuss it just prior to coming on air.
We did.
Okay.
I'm glad you cleared that up with the YouTube video.
But in all seriousness, what am I doing at the moment?
Yeah, what projects have you got on the go?
A lot of advanced care planning. So in palliative care, I'm lead for advanced care planning for Wales. So things like do not attempt cardiopulmonary resuscitation, decisions and discussions, and advanced decisions to refuse treatment, all sort of treatment escalation decisions in Wales. And we've got a group for that where we kind of try and move things forward, get lots of patient engagement, patient involvement. Yeah, so it's one of those topics that is going to be very, very difficult to talk at with a huge amount of humour on this podcast.
We're renowned for our humour, Mark.
Yeah, lack of humour is not one of our things we have to worry about.
Okay, then do not attempt cardiopulmonary resuscitation decisions. Make a joke about that one. Come on, I dare you.
STC?
I haven't got a joke, but and forgive me if this is a really tough opening question, Mark, but given that Wales led the way, didn't they, I think, in relation to transplant, where you have to opt out of transplantation.
Oh, yeah.
Is there anything... So I worked with a physician once who shall remain nameless, and he did say he was really out there, but he used to say, because of all the confusion about do not resuscitate records, that he felt that after a certain age, you'd have to opt in to have CPR rather than the other way around. Is that completely nuts?
I've heard this argument before, but you can't just put sort of blanket policies like that forward on such a controversial topic. And I'll tell you why. I've resuscitated 90-year-olds who were probably fitter than some 40-year-olds I know, and whose heart was stronger. And what went wrong with them was they went into an abnormal heart rhythm, and all it needed was 2 or 3 shocks and they came out of it. And the next day they were feeling much better again. So often blanket policies like that don't work. It has to be very nuanced, and it can never be sort of age-based or based on certain criteria. So yeah, if you ever take the time, Steve, to read the newest All Wales DNA CPR policy, which spans about 39 pages, I'll send it to you after this meeting, by the way. Then you can see in there that we don't do sort of blanket policies and that sort of thing, and then it can go really wrong as well. I don't know if during COVID you heard this, but there was a letter sent by a GP to all sort of elderly patients in the practice suggesting a DNA CPR form, and it went down like a lead balloon, basically.
That's what I was going to say. That's often when it runs into trouble, isn't it? Is when you try and have a blanket policy that can only ever cover a certain amount of situations, and that's where the skill of people like yourselves come in, isn't it? Is understanding the nuance and context.
That's right. There's a lot of grey zones, and your friend or colleague Steve, was he a surgeon? Because grey zones are not so clear. It's like black or white. That's it.
It's a laugh a minute at the moment, anyway. Great.
Yeah, we like talking about the grey though. We agree as clinicians, pharmacists generally are not very good in the grey, and we take our lead, I think, from doctors who are much better in the grey. But I hear what you're saying. There are doctors and there are surgeons.
Yeah, and I mean, if any listeners feel offended by anything that we are saying right now, then I would say, I mean, I work in palliative care, I work in hospices and cancer centres. The people with often the blackest sense of humour are some of my patients, basically. So we do talk about these topics, and a lot of my patients actually say to some of their relatives, come on, cheer up. I have actually had patients where we've made jokes about some of these really difficult topics as well. So
one of the things we talked about last week, Mark, was resilience, and so I guess that's something that you must have to have in spades, really.
Yeah, I think so. I mean, and humour does definitely help in some of the maybe darker areas of life and medicine in general. I mean, the first time I set foot in a hospice, I was expecting there would be a solemn sort of place, slightly dark, everyone walking around sort of respectfully, and it was exactly the opposite. I mean, it was people laughing, people milling around, and just generally it was such a good atmosphere. I was just really taken aback by it. And a lot of patients and their families sort of say, we don't want everything to change just because I've got a terminal illness now. We don't want people to sort of traipse about and say, oh, I hope everything's okay, and worry about saying the wrong things. Actually, most people just want you to act normally around others, and things haven't changed so much that you can't just share a joke occasionally as well. So that's my attitude anyway, and I think a lot of patients I see, they appreciate it.
Thanks, Mark. I've just realised, Mark, can you remember the last time we met?
Yeah, was it in Llandoch Hospital?
It was. I was enjoying a refresher course back to hospital pharmacy, taking a well-earned break, having a coffee in the refectory, and in you came. And who did you pass on to me?
Oh, I had a medical student with me. No, not medical student. A newly trained doctor who's also an international rugby player, Jamie Roberts, with me, who was spending the morning and early part of the afternoon with me.
Yeah, so I mean, he just spent some time with you. He sat down with me. I had a 45-minute cup of coffee with him, and then he came down to the pharmacy department then, and he was writing his blog for what he was seeing during the early part of COVID. He'd never been in a hospital pharmacy before, so he came in, he chatted to the staff, saw the robots, spent time talking to the clinical trials pharmacist, and it was really interesting to see the effect that having rugby players in Wales are celebrities, to see the impact that he had on morale around the department, and he really put a spring in people's step, and I could see that he asked some great questions and he really listened to the answers too. Yeah, that was great, thank you.
And he was fab on the palliative care ward round as well. So he saw a lot of my patients, and some recognised him, some didn't recognise him, but one of my very young patients who's in his 20s, he's a big rugby fan, so he got very excited. That was fantastic, and then I kind of handed him over to you, basically, the two Jamies.
Thank you.
But listening is what you guys do best, isn't isn't it, as palliative care people?
Yeah, I mean, that's one of the skills. I think it's definitely something that we need to do, but also kind of allowing people to say certain things and being there, but also letting them to talk about things. So you have to listen, but in some ways, maybe you have to sort of direct it towards the topics that patients don't feel they can talk about, maybe, and feel awkward talking about. I mean, a lot of my patients, they say to me that at some point or another, they would have actually quite liked to have talked to their surgeon or their oncologist or their medical consultant about, what might happen in the last days, weeks, months, even year of life. But there's not sort of the culture for that. And actually doing that may seem a bit weird or a bit cookie or a bit edgy, basically. And so everyone just focuses on the drugs and the treatment regimens and the surgery or the chemotherapy or the immunotherapy. That's what you're there for. People often maybe don't dare ask those questions so much sometimes, whereas I invite it and I say to people, you can talk about this if you want to, but if you don't want to talk about it and it's a bit sensitive, then let's talk about something different.
So, Mark, I've heard you describe that as clinical bravery, if you like. Is that correct?
Yes. I mean, that sounds then a bit self-aggrandizing nearly, doesn't it? And I'm uncomfortable with that. Just because I do it doesn't mean it's particularly brave. I think sometimes maybe taking some risks a bit sometimes with a patient when you notice it's going in a certain direction. I sometimes bring up things like when it comes to certain drugs I prescribe, I'll say, some of my patients ask me about this and they worry about addiction when it comes to opioids. Have you had those fears? And then they'll say, yes, that is something I have actually worried about and I'm concerned about. You get to know people a little bit and you get to know what most people's darker fears are in the background that they don't come out with. And you can tell it in their eyes sometimes if they've got a question, but they're not quite sure, A, how to ask it, or B, whether they can ask it. Maybe it is brave, I don't know.
The other thing I was going to ask you, Mark, was I'm sure you will have read, but we'll ask you in a minute about your book for the Oral Apothecary, but my book from the beginning was always going to be Atul Gawande, Being Mortal, Medicine and What Matters in the End. And I'm sure, having heard and seen some of the stuff that you've written, that a lot of what he talks about resonates a lot, does it not? And in relation to trying to be upfront about escalation of care and ceiling of care. And that's a very, very difficult conversation, is it not?
Yes, it is. I mean, and it's a fantastic book. When I read it, I recognized a lot of the sort of areas in there that were relevant to my life. I don't actually like ceiling of care as a concept so much. I often go for ceiling of treatment because I suppose words and phrases are important and there should never be a ceiling to good care, because sometimes you hear a patient say, well, the surgeon said to me, that's it, nothing further can be done. And that's never true. Something else can always be done, from making a cup of tea to a patient to prescribing some medicines that stop the nausea to helping with pain so that they can mobilize a little bit. There's something can always be done, and care is sort of ceilingness. And, I don't want this to sound too cliched or too cheesy, but it should be ceilings of treatment in many ways. So that's Atul Gawande's book is absolutely fantastic.
Yeah, I always recommend it to everybody. It's just so holistic in the way he talks about care generally. But yes, I shall definitely take your learning there around ceiling of treatment. I like that. Okay, so that's been a great chat, and hopefully the listeners have really enjoyed that. As you well know, probably, Mark, the whole reason for coming on the Oral Apothecary really is to be able to give us, to begin with, a desert island drug. And I'm sure you're aware that this is about a drug that has a very strong emotional contract for you, whatever it might be. What would you like to give us?
Morphine. Yeah. I would like to give you some morphine.
Anytime.
No, morphine is my drug of choice. I did think long and hard about this because I read the sort of briefing about this.
You're going to have to go some now, Mark, okay? Your palliative care consultant coming in with morphine.
Because, the brief was not the drug that you want for the desert island. It's more the drug that is important to you, basically, that brings in powerful memories.
Yes.
From life, career, and stories, and that sort of thing. And whilst I've never ingested or been
inhaled
an opium fiend, if you like. I didn't inhale. Honestly, I didn't. I've always been fascinated by it. Let's put it this way. From reading about it in the literature and reading about it in different books to medical school. I was always interested in the pharmacology of opioids and some of the drugs that we often use in palliative care. I think that's a really a strong point in palliative care. The pharmacology is just absolutely fascinating to the whole sort of history of it, sort of the opium poppy and Papaver somniferum, and the name of it and where it's grown and what happens with it. You'll have heard, and you know that I'm German, and morphine was first isolated, I think at the start of the 19th century by a German scientist, Friedrich Sertürmer, who called it morphium at the time. And then it was sort of commercially marketed by Merck back in the 1820s. And the name morphium came from Morpheus, the Greek god of dreams. So it's absolutely a wonderful drug, and it still does so much for us. It helps us in so many different ways.